It's still 11:59, so I guess good morning, everyone. I wanted to thank Dr. Brooks and Dr. Walsh for the opportunity and the SAGES for the invitation for me to participate in this panel. I'm going to be talking about a common problem that many of us kind of hear about and often have to deal with. I have some disclosures. Most of this relate to intestinal glucose absorption, so should have no relevance to what we're going to talk about today. So it is well documented and well discussed that in pregnancy, incidence of gallbladder disease goes up. And this is thought to be due to changes in the bile acid composition and hepatoenteric bile salt circulation, and also reduce in gallbladder ejection fraction, which is caused by changes in progesterone levels. Now, in a recent study, they actually did an ultrasound assessment of ejection fraction in a group of pregnant ladies, and they found that if you looked at this lady at the age of sort of 12 to 14 weeks of gestation, they had an ejection fraction of 56%, but by the third trimester, this was reduced to 48. Now, on initial assessment, it frankly didn't look that impressive to me, and it didn't look a very convincing etiological factor. But what they did, they actually then looked at patients who during this period ended up having gallstones and compared them to a group who didn't have gallstones. And there was a big difference. So ejection fraction for the people with gallstone was nearly half of the patients without, suggesting that this hormonal change and this alteration in progesterone could be a contributing factor. So when you take a group of pregnant women who, and at baseline, and baseline usually means at around 12 to 14 weeks of gestation, if they have an ultrasound, they have no gallstones. It was believed that if you follow them to the end of the pregnancy, about 31% develop sludge and about 2% develop new stones. Now, this was based on some data from the early 90s, an Italian study. And when actually you look at the more recent data on this, in this kind of design concept, it turns out the sludge rate may actually be less. So this is based on studies that were done in the last 3 years or so in Iran, Turkey, and the US, showing that the new sludge formation rate is actually probably lower at around 6 to 8%, but the stone formation is actually the same, around 2 to 3. And in women who are older and who've had multiple pregnancy, that risk of stone formation tends to be higher. Now, whether the sludge is actually 6 or 8 or 31% may not really matter that much, because subsequent assessments have shown that in terms of developing symptoms or biliary symptoms during pregnancy, sludge actually has very little correlation, and is actually that people who have stones tend to develop the symptoms. And on average, about 30% of patients who have gallstones develop symptomatic or at least one episode of symptoms during their pregnancy. And about a quarter of these patients ultimately require to have an intervention during their gestational period. So what this adds up to when you do all the maths, it turns out around 1 in 1,500 to 1 in 10,000 patients end up having a cholecystectomy during pregnancy, making it the second most common non-obstetric procedure in pregnancy after appendicitis, which I think you're going to hear about next. Like non-pregnant patients, gallstones can lead to a variety of symptoms in pregnancy. So the most common tends to be biliary colic, which occurs in about just over 50% of cases. The next is this. I've actually put common bile duct stones and pancreatitis together, and that's about 35%. And acute cholecystitis tends to be around 15%. And I was hoping to provide a kind of a detailed, data-driven assessment of each one of these diagnoses, but as we have talked about before, there's actually very little quality data or certainly large seriousness about this. So I'm going to make a general few comments about symptomatic gallstones in general, and then focus on each specific disease. So diagnosis of biliary disease in women, actually in pregnant women, can be quite difficult. So why is that? The reason is because many of the symptoms that we usually deal with biliary disease actually exist in pregnancy. You know, incidence of reflux disease is higher. People often have abdominal pain. So things that we may help us distinguish biliary disease are sometimes confounded with the physiological changes of pregnancy. Abdominal exam becomes more difficult, so people always hear about the organs moving around and the appendix moving up. Now, how common that is, that's probably not that common, but certainly it's something that can confound a physical exam. And the other thing is that blood tests that we often rely on, so if kind of an elevated white count or an elevated alkaline phosphatase to kind of help us direct us towards biliary disease, are normally elevated in normal pregnancy. So again, that cannot be helpful. And we briefly touched about sometimes imaging choices that we make to help us with the diagnosis can be altered and influenced by the presence of pregnancy. Now, for biliary disease, we have the ultrasound, which is a safe, super reproducible test, so that's lucky. But in cases such as appendicitis, this actually ends up playing a big role. And as Dr. Walsh alluded to earlier, you know, assessing a pregnant lady is actually very anxiety generating. So for myself, when I get a page to go to the labor floor, I kind of get palpitations before I even have run up the stairs. And that's because you're really assessing two patients. You're assessing the mother, you're assessing the baby, and you're also dealing with often a very emotionally charged environment where there's kind of anxiety about the child, the mother, and the father is involved, and it's hard to handle. And because of this, I think traditionally we have favored a kind of a non-operative management to these problems. And although, frankly, this has been a simple way of dealing with the problem, it's not ideal. And I think what over the few years we have started to change and kind of start to consider is actually the well-being of the mother as well, because a happy mother usually means a happy fetus, a happy pregnancy. And there's also been increasing evidence to document safety of surgery and various other interventions during pregnancy, as we have alluded to earlier. So I'm going to highlight some papers that came out over the last few years that, in terms of biliary disease, suggested that intervening early is actually fine and safe. So I'm going to give some credit to our moderator, Dr. David Brooks, who kind of published this paper several years ago using a Markov analytical model, and showed that in terms of patients with biliary symptoms, a laparoscopic cholecystectomy was superior to an operative management in the first and second trimester of pregnancy. Now, these kind of analytical models have their certain limitations, but certainly this was a great start to start suggesting that surgery at an early stage is good. Another interesting paper which caught my attention was this that was published about a year ago, and in this paper they looked at 112 pregnancies. The patients had a combination of symptoms. 56 or about 50% had biliary colic. The others had cholecystitis, pancreatitis, Gallbladder. So it was a hodgepodge of biliary symptoms. But what they did is they looked at the group that was managed conservatively versus the ones that were treated surgically. So I'm sorry if this doesn't project well, but what they showed was that in a group that was managed conservatively, 60% during the remainder of the pregnancy ended up having recurrent symptoms with an average of 1.7 visits to the emergency room, 1.5 admissions. And those numbers were significantly less for patients who were managed surgically. Now, people worry about, okay, but maybe that came at a cost to the baby or the fetus. So it turns out maternal and fetal morbidity and mortality were similar, but also, interestingly, the rate of cesarean section in the actively treated, the patients who actually had cholecystectomy, was less, because they kind of hypothesized that some people, because of ongoing biliary symptoms, had to be induced and have an earlier delivery. And although the baby's weight didn't reach a significance, it tended to show a trend towards the babies also being weighing healthier and better. The largest study looking at incidence, prevalence of laparoscopic surgery in at a population level was this study from Yale that used the national database and identified 37,000 nearly pregnancies, 9,700 of which is about a quarter, had undergone cholecystectomy. And what they showed was that the group that had surgery had a lower maternal and fetal complication rate, so 6 versus 6%, although the cost and length of stay was higher. Now, so this, you could use this as a big argument that we actually should be doing surgery, but I would caution about that interpretation because the groups were actually a little bit different in terms of age and comorbidities. What the group did, although in a kind of a subgroup analysis, they looked at the patients that had surgery, so the 9,500 that had cholecystectomy, controlled for various variables, and showed that laparoscopic cholecystectomy actually had much better outcomes in terms of fewer maternal and fetal complications than open surgery. And that was quite a big reduction, 5% versus 11%. And obviously, this data we've already talked about led to the most recent SAGE's position statement, which advocates for laparoscopy in management of biliary disease in pregnancy. And the level of evidence is actually pretty good, moderate, strong. So now that we kind of have that out of the way that we should operate, I was going to try to provide a little bit more scientific data about how each of these specific symptom categories should be managed. So as we talked about, biliary colic is the most common presenting symptoms in pregnancy. And it's hard to diagnose because, as we mentioned before, other confounding symptoms that are brought up with gestation also can mimic the symptoms, and specifically GERD and sometimes constipation and premature uterine contraction or fatty liver of the pregnancy. And we've also said that some of the tests that help us with this diagnosis are sometimes a slightly elevated white count or a slightly elevated alk phos are normal findings in pregnancy, and that cannot help. Fortunately, we do have the ultrasound to help us with the diagnosis of gallstones, and despite pregnancy and the physiological changes, it remains a very sensitive and specific test for gallstones in this setting. Now, how do we manage this? So a lot of the time, to be honest, the attacks are fairly mild, maybe infrequent, and they can be managed maybe non-operatively with dietary changes, not too indifferent to what some of the non-pregnant patients opt to do. However, for more frequent and more severe symptoms, there's certainly plenty of data to support intervention by form of a laparoscopic cholecystectomy. This issue of ideally when to do this has come up, and although there is evidence that we can kind of potentially do this at any trimester, as Dr. Wright suggested, the educational material and perception outside is very hard to change and is certainly lagging behind this. So second trimester keeps to be an ongoing issue. And in fact, I had this issue like a month ago with an emergency room doctor at one of our nearby hospitals who did not want to have the gallbladder out despite having a terrible time with the gallstones until she was later in the second trimester. So what about pancreatitis and common bile duct stones? So again, this history of the diagnosis of pancreatitis can be made using history. We have the serum chemistry in this case, which is usually reliable, and abdominal ultrasounds. Sometimes for pancreatitis, we perform CT scans of the abdomen. Now, it's, as Dr. Rice mentioned, it is safe to do a CT scan of the abdomen because the radiation amount is less than the 5 rad. But a lot of the time, people may opt to do an MRCP because it gives more specific information about the pancreas and also the biliary tree, which can help with the management. This is actually a paper that we published a few years ago looking at our own institutional experience with pancreatitis in pregnancy. So I have to admit, it's not the N in this study is only 21, so very low, but at the time it was actually one of the largest series, and I think this highlights the challenge in making treatment recommendations because all the numbers are actually very small. Based on this study, we found that we estimated that the prevalence of prevalence of overall pancreatitis in pregnancy was about 0.02%. Our study was a little bit different from other studies, which have shown that the incidence of pancreatitis increases with pregnancy, but we actually found a higher incidence in the second trimester. And about 60% of the incident pancreatitis diagnosed were biliary. So this is actually important to realize that not every pancreatitis in pregnancy is biliary in origin. We had 12 cases of biliary pancreatitis, and in 6 of them, we operated on them. And the indication for surgery was kind of fresh primary biliary pancreatitis, but a third had actually had pancreatitis before, not had surgery, and come back with recurrent symptoms and ended up having surgery. 2 had ERCPs, and 4 were treated initially conservatively, but 50% came back with recurrent symptoms during the remainder of the pregnancy, ultimately requiring a cholecystectomy. So I think this highlights what was discussed before, is that if people have symptoms and, under normal circumstances, your treatment algorithm would involve surgery, I think there's no reason to avoid this option for patients. And we went on to show that in the group that had had surgery versus conservative treatment, there was actually no difference in length of stay, maternal or fetal outcomes, and our conclusion was that early surgical intervention should be considered in these patients, and subsequent studies have actually confirmed this finding as well. One of the complex issues is the role of ERCP in patients with either pancreatitis or common bile duct stones. And there's concern about radiation and actually overall safety of the procedure. I'm by no means an ERCP expert, but there are papers out there in summary that show that ERCP is safe in pregnancy. There are ways that can be utilized to minimize the dose of radiation by shielding the uterus, the clinician minimizing the radiation exposure, and keeping it well below the safety threshold that you heard earlier. In a large study of 68 procedures, there was some concern, and it's been hard to kind of further validate this, that the risk of post-ERCP pancreatitis may be higher in patients who have pregnant patients who have ERCP. And also, if you do an ERCP in the first trimester, the first risk of preterm labor, so this is not premature labor, this is not something that happens around the time of the procedure, but several months later, the risk of preterm labor may be higher, although I actually don't know why that is. And I'm going to just lastly talk about acute cholecystitis. So again, for reasons we've discussed before, it's a difficult diagnosis. Fortunately, we have the ultrasound to help us make the diagnosis. And in cases that there's uncertainty, HIDA scan can be utilized, and the radiation dosage is very minimal and should be safe for the baby. The big dilemma, as with anything, is conservative versus surgical therapy. And this is interesting because even if you deal with a non-pregnant patient, there's a lot of dilemma about what you do with the acute setting. But so ultimately, I think this, whether you operate or not, often depends on patient preference, surgical preferences, and also maybe gestational age. It should be pointed out, and this was a study that, it was actually a review of multiple studies that was published a few years ago in American Journal of Surgery. And they looked at the group of patients that had cholecystitis. So I have to admit, I don't know if this meant all acute cholecystitis or whether this was just a chronic and acute mixture. They showed that the group that had surgery actually there was no difference in maternal and fetal outcomes. But again, if you didn't operate, about a third failed treatment and ended up having to be readmitted and having surgery. Now, so although the message in general is that if patients have symptoms, you should plan to operate and relieve the mother of the symptoms because the happy mother will be a happy pregnancy and a happy baby, some don't do surgery and some patients don't want to have surgery. So the question becomes, what do you do with them if they go through the pregnancy and then you have them at the end? Do you need to do anything about gallstones? So what I would say, there's a good amount of evidence that in terms of sludge, 40 to 60% of the sludge is resolved within the kind of early first few months after the pregnancy. And although the evidence for stones resolving is less robust, there is evidence that some of them dissolve as well. So I think if patients have had pancreatitis or serious kind of complications, it's certainly reasonable to think about a cholecystectomy. But if the symptoms was just a mild biliary colic and they're not asymptomatic, it's reasonable to monitor them with a repeat ultrasound to see if the stones disappear. Thank you.
Thank you very much, Alan.